Good morning again. Let's move forward. My disclosures, cases. We're going to answer those questions of what to do with phosphorus, calcium, PTH, how to use 125D, how to use cinacalcet, how to use vitamin D. I'm going to try to do it all. 46-year-old female who presents with adult onset diabetes mellitus for 20 years. Retinopathy, gastroenteropathy, her renal biopsy, which we didn't do and we would have not done, was consistent with diabetic nephropathy. She's on some sevelamer, she's on calcium carbonate. Begun on hemodialysis, and 3 months later found to be frankly hypercalcemic. So what is the probable cause of her hypercalcemia? Does she have hyperparathyroidism, either primary, secondary, or tertiary? Does she have hypercalcemia of malignancy, immobilization, vitamin D intoxication, or excess FGF23? Well, from the last lecture, you know she can't possibly have excess FGF23 since it's a phosphaturic hormone, doesn't affect calcium very much. Could she be immobilized? Not likely. No indication that she is. Vitamin D intoxication is always possible, as is hypercalcemia of malignancy and hyperparathyroidism. This is a real case. All the cases we're going to talk about are real. So she comes on to dialysis with a high phosphorus. We know that this is a prescription for death, and her calcium keeps going up. 12, 11, phosphorus is high, alk phos a bit high, 25D is certainly sufficient. Her PTH is 200. Now, a PTH of 200 in a dialysis patient isn't that high. The old KDOQI said 150 to 300. The new KDIGO says up to about 560 or 600. Not that high. Certainly does not explain that calcium of 12.2. Let's think about a PTH assay. Years ago, the PTH assays either targeted the amino terminal side or the carboxy terminal side of 1 to 84 PTH. It just was an antibody, had a signal, in this case radioactive iodine, could be lots of signals. The newer assays, the better assays, the assays your hospital should be using, connect to a solid phase a primary antibody which latches onto the parathyroid hormone itself. You then put in a secondary antibody, which is the signaling antibody. You rinse all that off. The only thing that should count for the assay is that PTH, which is adhered at one side, let's say the amino terminal side, adhered at the other side, which is the carboxy terminal side, and signals. So this is PTH 1 to 84. This is the old carboxy terminal assays. Useless, horrendous, should never be used. The amino terminal assays were a bit better, but suffered from the fact that there's a lot of waste product here that isn't biologically active, but some of it includes what's detected, so it's not a good assay. The first generation immunometric assays had a detection on the amino side, and then, or captured on the carboxy side, that would latch on first, and then you'd have the detection on the amino terminal side. These assays have gotten better, and how they've gotten better is the capture. Okay, so this is the capture antibody. This is the detection antibody. So the capture is on late in the carboxy terminal, but more importantly, the detection is early on the amino terminal side. So the only thing that gets detected is the 1 to 84 biologically active PTH. Make sure your lab is using a good assay. There's some really good assays out there. There's some less good assays. So what does she have? She's hypercalcemic. She has a high PTH. Does she have primary hyperparathyroidism and adenoma in one of the glands that's causing PTH to go up. Remember, her PTH is 200, but she's really hypercalcemic. Does she have secondary hyperparathyroidism, which means the PTH is going up because of the signals, let's say a low calcium stimulating PTH? Does she have refractory secondary hyperparathyroidism, which means it's secondary to something, but it's no longer responsive to the normal signals? We oftentimes see this in our patients on dialysis. Does she have tertiary hyperparathyroidism, which is refractory secondary with hypercalcemia? That's certainly possible that she has primary. She probably doesn't have secondary because her calcium is high. She probably doesn't have refractory secondary because her calcium is high. So she could have primary or tertiary, or maybe we're giving her too much vitamin D, or she's getting vitamin D from something else. So we did a parathyroid scan, a sestamibi scan. She had a single large nodule below the left lobe of the thyroid. This is critical. If she had tertiary, she'd have 4 big glands. If she has primary, she has 1 gland. Perfect test. Less perfect computer. Chest x-ray was normal. Her mammogram was also normal. You always want to check that with hypercalcemia, especially in a woman of this vintage. This is the sestamibi scan. Initially, you see the thyroid and parathyroid light up, but with time, you see the parathyroid gland. It's absolutely critical in every one of these cases to do at the same time a view of the chest. Your radiologist might say, oh, it takes too long because it takes a long time to scan this. But you have to, because there's cases where the offending gland is sitting in the chest. So this is a perfect diagnostic test. The surgeon knows exactly where to go in, can pull out the gland. So this woman had primary hyperparathyroidism. You're expecting me to present a case of secondary hyperparathyroidism because that's what we see. But you also see primary hyperparathyroidism. It's a not uncommon diagnosis. 7% of our Stone Clinic patients have primary hyperparathyroidism. The other glands were slightly hyperplastic. The surgeon did what surgeons like to do. He took out some of the glands. Calciums came down and was normal at discharge. Simple case of primary hyperparathyroidism. As I told you, autonomous secretion is primary hyperparathyroidism. Secondary is the response to normal regulatory stimuli, usually hypocalcemia. Refractory secondary is when you can't suppress the secretion after you correct these primary regulatory stimuli. And tertiary is with hypercalcemia. So she could have had primary, she could have had tertiary. The sestamibi scan showed 1 gland enlarged. You have your diagnosis. Very good test. We know PTH, as I told you before, is regulated principally by calcium through the calcium sensing receptor. A low calcium stimulates secretion. We said a high 125D inhibits secretion, and a high phosphate stimulates secretion, but these are minor regulators compared to calcium. In the kidney, PTH stimulates the reabsorption of calcium and inhibits the reabsorption of phosphate, so it will raise serum calcium and lower serum phosphate. It's phosphaturic. Increases the activity of the 1-alpha hydroxylase, so you get more 125D. In bone, a high PTH causes increased bone turnover. I showed you the pictures, increased resorption of calcium, increased resorption of phosphorus. It's very hard to get your patient's phosphate down if they have a high PTH, and you see why, because the bone is contributing phosphate to the systemic phosphorus pool. We know that small intermittent doses can stimulate bone formation, but the levels we see in our dialysis patients aren't here. PTH has no direct effect on the intestine. That's been a board question for decades. If you understand this graph by Monroe-Peacock, you understand PTH. Fasting hypoparathyroid patients have low serum calcium, little calcium excretion. Fasting hyperparathyroid patients, right, with the line through it, have high serum calcium. This is the normal 95% confidence interval. If you take a hypoparathyroid patient and infuse calcium, serum calcium goes up, but urine calcium really goes up because there's no PTH to hold on to that calcium at the level of the kidney. You get hypercalciuric. Same thing happens with high PTH because as you infuse calcium, the filtered load of calcium exceeds the ability of the high PTH to reabsorb calcium, so you get even more hypercalcemia, but you also get some hypercalciuria. Think about this diagram. If you understand it, you understand PTH. Net effect on calcium homeostasis: blood calcium increases, phosphorus decreases, and urine calcium excretion increases because, as I said, the increase in filtered load exceeds the increase in tubular reabsorption. Why is this important? Because, as I said, 7% of my Stone Clinic patients have primary hyperparathyroidism. Because of this increase in urine calcium excretion, they form stones. I saw an orthopedic surgeon, retired, went through a bunch of doctors because he had kidney stones. He simply had primary hyperparathyroidism. And the cure, of course, is surgical. So excess PTH stimulates 125D. The increase in 125D stimulates calcium absorption. The increase in PTH increases bone resorption, increases bone formation, but the increase in resorption is greater than the increase in formation. If you have calcium coming in from the bone, calcium coming in from the gut, ECF calcium goes up. This filtered load of calcium, 2 arrows, increases the fractional reabsorption of calcium, and urine calcium goes up. Understand this diagram, you'll have a good sense of PTH. Now, how about the assays for PTH? This is from Gino Segre, who's at the Mass General. Beautiful paper, many years ago, still holds true today. Normal levels, primary hyperparathyroidism. Notice the overlap. There are patients who overlap. If you're concerned that the patient has primary, but the level's a little low, or normal, but the level's a little high, wait a few months, repeat the assay. This is not a medical emergency. Hypercalcemia of malignancy should have a low PTH. Hyperthyroidism, it says para, but it's hyperthyroidism, also will have a low PTH because the excess thyroid hormone stimulates some bone resorption, raises calcium a little bit. This is the key difference. PTH-RP, right? PTH-related protein, which you can send out for. If you're looking for humoral hypercalcemia of malignancy, look at how high it is compared to normal. Again, there's overlap. Repeat the test. If you repeat the test, these tend to segregate nicely. Note, everything else has a low PTH-RP, except, and you're never going to measure this, but it's fascinating, breast milk. You know how women secrete all that calcium to feed their babies? PTH-RP. Fascinating. You learned something this morning. Indications for surgery: stones, fractures, symptomatic hypercalcemia. You got it. These haven't changed in decades. This is excess PTH, bone resorption, brown tumors. Hopefully you'll never see this again. If you have, someone's not been paying attention to the patient. You can see how fracture prone these bones are. If you can't find the gland, you have to, in the first surgery, you have to start looking in other places. Remember I said it's critical to get the chest? Well, because this is where a fair number of those glands that can't be found with initial surgery are lying. Cinacalcet is approved for treatment of dialysis patients with secondary hyperparathyroidism, not for CKD patients. CKD patients will become hypocalcemic and hyperphosphatemic if you use cinacalcet on them. It's been shown in 2 studies. It's not approved, and it's more than that. It's a bad idea in CKD patients. Approved for treatment of parathyroid carcinoma, and patients with primary hyperparathyroidism who cannot have surgery. Have a little old lady who has such severe arthritis that she can't extend her neck, she's doing well on cinacalcet. We tend to use it following kidney transplant in patients with hyperparathyroidism, though there's a lot of controversy if these patients, after a year or two, would benefit more from surgery. Recent paper in the New England Journal. The calcium sensing receptor is how calcium is detected. In the thick ascending limit, an increased peritubular calcium decreases calcium reabsorption through reduced activity of the potassium channel. More importantly, in the collecting duct, the elevated calcium inhibits water reabsorption. This is brilliant. If you're hypercalciuric, you'll be polyuric, and you won't form a kidney stone. Of course, the patient, if they can't keep up with the water, becomes volume depleted. This is the most important slide of the last 10 minutes. Calcium sensing receptor. If you have a patient who's hypercalcemic and has an elevated PTH, you have to check urine calcium excretion, because there's not an insignificant number of patients with FHH, familial hypocalciuric hypercalcemia. They look for the whole world like they have primary hyperparathyroidism, but urine calcium excretion is low. If they have an activating mutation, they look just like they're on cinacalcet. Just leave them alone. You have to leave these patients alone. Don't send them to surgery. How can you tell the difference? You get a 24-hour urine. If the urine calcium is less than 100, don't send them to a surgeon. They may well have FHH. Send them to your geneticist who can get a sequence of the calcium sensing receptor, and you'll see it's abnormal. This is key. Primary hyperparathyroid patients are hypercalciuric. If they have FHH, they're hypocalciuric. And often there's questions on the boards on this one. Next patient, 35-year-old, white male, had PKD. Diagnosis made at age 27 when he was in the Army. No medical follow-up. Patient is adopted, no family history. Limited education, poor understanding of his disease. He complains of polyuria and back pain. Okay? When we first saw him, his CO2 was 15, significant metabolic acidosis. Not part of our lecture today, but we know that treatment of metabolic acidosis with sodium bicarbonate has been shown in at least 1 and now 2 studies to prolong renal survival. That's well outside the realm of what we're talking about today. His calcium is 9.3, creatinine 9.3, BUN 111. So guy's got significant CKD. His calcium is high. His phosphorus is high. This is a bad combination. He refused his phosphate binders. He delayed getting access. 3 months later, he began hemodialysis when his BUN was 134, creatinine was 9, calcium was markedly elevated, phosphorus was elevated. He missed his treatments, he had abbreviated treatments. So, he's hypercalcemic. Does this guy have primary hyperparathyroidism? Does he have secondary hyperparathyroidism? Does he have refractory? Does he have tertiary? Does he have excess vitamin D? Every time you see a hypercalcemic dialysis patient, this is what should go through your mind. The 5 is easy because you're providing the activated vitamin D. If you're giving too much, he'll become hyperphosphatemic and hypercalcemic. Primary, secondary, refractory, secondary, or tertiary. Well, he could have primary. He's hypercalcemic, so he probably doesn't have secondary. But he could have refractory, secondary, but no, wait, he's hypercalcemic. He doesn't have that. But could he have tertiary hyperparathyroidism, which is secondary, which is refractory to the normal stimuli, leading to hypercalcemia? This is your differential every time you see one of these patients, and these patients are not rare. He's admitted with a renal cyst with Klebsiella, calcium's high, phosphorus is high, PTH over 1,000, 125D. I don't know why it was measured. I guess in hypercalcemic patients you probably want to measure it. Got a parathyroid ultrasound. They found 2 glands on ultrasound, but he had calcification. Look at this calcification. He would intermittently show up for dialysis. He finally agreed to a parathyroidectomy when he had multiple soft tissue calcifications, ulcerations, and some calciphylaxis. You see more calcifications, more calcifications. This is the other shoulder. Went to surgery. 2 big glands on the left, 1 big gland on the right. They couldn't find the right lower gland. They resected an entire lobe of the thyroid on the right. They couldn't find parathyroid tissue. They reimplanted some tissue in the right forearm. This is another discussion of what the surgeon should do. We don't do this much anymore. Post-op day 6, yes, calcium came down, but look at that PTH. We didn't solve the problem here. What do you do next? Do you get a 125D level? Well, we have it and it's not helpful. Do we get a DEXA for bone mineral? Do we get a DEXA for bone mineral density? Don't want to do that. It's not going to help us. Do we get a bone scan? It's not going to help us. Do we get a parathyroid scan or a scan for ectopic parathyroid tissue? This is a trick question because every parathyroid scan should scan for ectopic tissue. And in fact, they did an MR scan of the neck, no evidence of an ectopic gland. They did the parathyroid scan. Finally, intense activity under the manubrial sternal joint. He was non-compliant. He was judged competent. This is the scan. Look at this gland showing up right where I showed you it would be in the picture. This is not that uncommon. When you get a parathyroid scan, you have to go into the chest, you have to look for this gland. And in fact, he was just non-adherent. He took milk off other patients' trays. He didn't like phosphate binders, DNR. He died essentially from calciphylaxis. Calcium high, phosphorus high, PTH quite high. They found on postmortem the 4th parathyroid gland just where the scan showed it was, huge gland. And clearly then he had secondary hyperparathyroidism that morphed into tertiary hyperparathyroidism. Surgery was the solution. If this could have been gotten earlier, he would have done better. You see calcium in the gastric mucosa in this patient. As you're secreting HCl into the lumen, you get bicarbonate into the tissue, right? And that bicarbonate raises the pH, which promotes calcium phosphate precipitation. There's calcium in the fundus, in the skin, in the vessels, bad vascular calcification. In the AV node. So how do we manage hyperphosphatemia? Diet is critical. As Dr. Tucker told you, if you could get a patient on a preservative-free, mostly vegetarian diet, phosphorus is not a problem. I'll show you a little data on that later. Conventional dialysis, we're dialyzing our patients, 12 hours a week? And they're absorbing phosphorus, certainly not excreting phosphorus 24/7. We can't keep up with normal dialysis with phosphorus accumulation. Nocturnal, it's terrific. We've got a nocturnal program. People are on dialysis for long periods of time. Phosphorus is down. They can eat pretty much whatever they want. I've talked to you about giving too much vitamin D because it will enhance calcium and phosphorus absorption. You've got to correct the hyperparathyroidism because a high PTH will cause that phosphorus to come out of bone. And if their PTH is high, and if you're giving them a lot of vitamin D in an effort to lower that PTH, and you're yelling at the patient that their phosphorus is too high, the patient should be yelling at you because you've given them the vitamin D that's causing the phosphorus absorption, and you're not dealing with the PTH. We have to use binders. Aluminum, we don't use anymore, still used in some countries, but aluminum's toxic to many organ systems. We don't have to use it. I'll show you that calcium is not a good choice either. But you have other choices now. Sevelamer, the iron-based binders, whether you choose the ones that increase iron absorption or not, and lanthanum. And there is, of course, the consideration of some lanthanum accumulation, which it does, but has not been shown to be toxic. So let's talk about this. The more protein I eat, the more phosphorus I eat. This is general meat-based protein. Animal-based protein, more protein, more phosphorus. However, if you can put a patient on a vegetarian diet, their phosphorus will be lower. This is a study carefully done. Vegetarian diet is open circles. You see at every point in the 24-hour cycle, the phosphorus is lower than in the meat-based diet. The calcium is also a little lower, so the PTH is a little higher, but vegetarian versus meat, no question, lower phosphorus. The big problem in the U.S. is the preservatives, and most countries, frankly. Most of the meat preservatives are trisodium phosphate that breaks down immediately in the intestine, and the phosphorus is absorbed. Try to get your patients away from processed foods. Phosphorus removal on dialysis. In my diet, before I told you, it's 1,200 milligrams of phosphorus to make it easy. This is 1,000 milligrams in this patient's diet. They're taking in 7,000 a week. They absorb about 60% of it, so they absorb about 4,200. We remove in a typical 4-hour dialysis session about 800 milligrams of phosphorus. So on the course of the week, we're removing 2,400 milligrams of phosphorus a week with dialysis. Well, here's the problem. You're absorbing 4,200, you're removing 2,400, you have a surfeit of 1,800. If I simply dialyze my patients 6 days a week, easy for me to say, of course hard to do, the balance is minus 600 because you're removing more phosphorus than the patient is absorbing. If we could dialyze our patients for longer or multiple times a week, they do much better with respect to phosphorus. We said we don't like to use aluminum-based binders. There are a lot of calcium-based binders being used out there. Magnesium is rarely used, and then there's a lot of aluminum and calcium-free. We're not going to talk about the differences in the iron-based binders, sevelamer, lanthanum. The big, in this country, it's really sevelamer versus calcium. That's what the market is, so let's talk about that a little bit. When Russo looked at patients pre-dialysis, controls had increased calcium score. Those on calcium carbonate had increased calcium scores. Those on sevelamer, and I'm using sevelamer as a proxy for non-calcium-based binders, there was no difference. Glenn Chertow did the so-called treat-to-goal study. He took patients, washed them out of all binders, those that remained hyperphosphatemic. He got a CT scan. 12 weeks of sevelamer versus 12 weeks of calcium to titrate, and then he extended the study for a year, checking the CT scan at 6 months and the CT scan at 52 weeks or 12 months. The goal was the old K-Doki guidelines. Look at what Glenn found. People on calcium-based binders, those who had some calcification, had a marked increase in coronary calcification compared to those on sevelamer, same increase in aortic calcification. This is a massive increase compared to a non-calcium-based binder. Glenn did it on prevalent dialysis patients. Jeff Block did the same study for 18 months on incident dialysis patients. Look at the difference. Calcium-based binders, non-calcium-based binders. At the end of 18 months, the coronary artery calcification score much higher on the calcium-based binders than on the non-calcium-based binders. And then Jeff continued his 18-month study and simply watched the patients for 60 months. Not a lot of patients left, right? But look at the divergence of the lines. Those that are on a non-calcium-based binder survived. Those that were on a calcium-based binder, not so much. This p-value by the end of the study was significant. Clear evidence that you can help your patients by avoiding calcium. To show what's going on, there were 2 studies in CKD patients. Spiegel did one. He took, these are formal balance studies, so your ends are going to be very small. Because, imagine a balance study. You're collecting everything that comes into a patient and everything, and I mean everything that goes out of a patient, and analyzing it. 6 patients with CKD, it'll come back, 6 healthy controls, put them on a low and a high calcium intake. This is close to your dietary calcium intake. This is not so high, 2,000 milligrams of calcium. Look at what happened. CKD on a low calcium, that's a normal amount of calcium. We're in neutral calcium balance. If they were on the high calcium diet, 2 grams, that's a couple of calcium carbonates. High calcium balance. They retain calcium. And there was no difference in fasting serum calcium. Remember, I said in the prior lecture, calcium is not a fuel gauge for how much calcium is in the body. You can have a patient with primary hyperparathyroidism, high serum calcium, their bones have low calcium. So this is one study. Katie Hill did the next study, CKD 3 patients, 8 patients, again, a formal balance study. Controlled diet, this is placebo, or controlled diet plus calcium carbonate, 500 milligrams 3 times a day. Look what happened. The intake obviously went up. The fecal went up, but not as much as the intake. These patients were retaining calcium. And again, this is 3 calcium carbonate pills a day. And again, no difference in serum calcium. So, Jeff Block then did a study in CKD patients, placebo, lanthanum, sevelamer, calcium. What he found, which surprised everybody, is the people, when he grouped all the binders together, the phosphorus went down. This is not surprising. Urine phosphorus went down a little bit because the phosphorus was bound in the intestine, less was absorbed. It's all perfect. What he found that shocked everybody is those people with CKD 3 and 4 that were on binders had more coronary artery calcification change, greater increase in coronary artery calcification than placebo. Small study, small groups, very provocative. As we're binding phosphorus in the intestine, are we allowing more calcium to be absorbed? We don't know, but this is concerning about using binders in patients with CKD. And of course, they're not approved for patients with CKD, but many people use them. If in the supplement you look at, he looked at the binders separately, this is the placebo, this is calcium, this is sevelamer, this is lanthanum. You see the calcium-based binder was the biggest offender. And again, suggests the use of calcium is not a good idea. We actually modeled this a few years ago, and we found, based on extensive modeling of change in extracellular calcium in dialysis patients who are not on any supplemental D can tolerate about 1.5 grams of elemental calcium. With vitamin D, they can tolerate about 1 gram of elemental calcium a day. That's diet plus binders. So not much calcium in addition to what's in their diet if you have them on vitamin D. We also just wrote an editorial, it literally just came out a few weeks ago, that we worry a lot about calcium-based binders. We also have to worry about the dialysate calcium. Many people are upping the dialysate-based calcium, the dialysate calcium. And we don't know if that's such a good idea because it's causing a massive calcium influx to our patients. And there are now 2 studies in the literature saying that going above about 2.5 leads to increased cardiovascular mortality. They're small studies, but this is the editorial that accompanied that was about one of the patients, one of the studies that increased dialysate calcium. Be very careful about doing that. There are 2 now large meta-analyses of calcium versus non-calcium-based binders. Sophie Jamal found that non-calcium-based binders had a 22% reduction in all-cause mortality compared to calcium-based binders. This is the last meta-analysis. It literally came out in CJASN this year. This is calcium versus sevelamer. And again, sevelamer is a proxy for the non-calcium-based binders. And probably the risk ratio is low. This favors sevelamer. This is sevelamer versus calcium acetate. Look at sevelamer versus calcium carbonate, the most common binder. The mortality here is a third if they're on sevelamer compared to calcium. The overall study, about a 50% reduction in mortality if your patient's on a non-calcium-based binder versus a calcium-based binder. I know these are cheap. I know these are readily available, but the data so far suggests that they kill patients. If you give a normal, I said this before at the end for the question and answer period, if you give a normal postmenopausal woman calcium and vitamin D, and we're talking about not activated vitamin D, but just, ergocalciferol, cholecalciferol, this is calcium, this is placebo, this is cumulative incidence of MI. Look at this, highly significant difference. Stroke is higher, not significant. The composite of stroke, MI, and death, 0.6, not quite significant. So this is Boland's data and Reed's data. The risk of MI is increased. The risk of stroke is increased. This is a meta-analysis. Would you want to be on calcium and vitamin D if you're a postmenopausal woman? Just about 1 study supports it. A ton of studies don't support using it. Placebo. We know that our patients have the old KDOQI guidelines. We'll get to new guidelines in a minute. We have pretty good data that if you can achieve these guidelines, your patients will do better. Why? This is Mark Denise's data. He took the number of patients that hit the guidelines for calcium, phosphorus, and PTH, those KDOQI guidelines that I showed you initially at the beginning of dialysis, and looked at mortality 2 and 3 years later. Those that hit all 3 guidelines did the best. Those who missed 1 but hit 2 didn't do as well. This is the increase in mortality, death. If they hit 1 target, didn't hit 2, they didn't do as well. If they didn't hit any targets, 51% increase in mortality. I don't know if I took this patient walking in the door and miraculously got him to hit all of the 3. Well, pointer just doesn't like me. Got them to hit all of the KDOQI targets, they would come back here. These are association studies, but this is pretty strong data. Mark also showed that time in range mattered. If your phosphorus was in control 4 out of 4 quarters, your patient did well. If they missed 1 quarter, their mortality went up. 2 quarters more, 3 quarters more. Calcium, not so much. PTH, not so much. I've been harping on phosphorus all morning for a reason. So KDIGO suggests keeping PTH 2 to 9 times the upper limit of normal. KDOQI commented on KDIGO and basically agreed, but we all know that mortality starts to go up at about 400. So do you need 150 to 300? Probably not. 150 to 400 is probably a little better. Can it go up to about 600? Maybe, but try to get it down. You don't want a PTH much above 400, especially sequentially. Calcium should kind of move toward the normal range. Higher calcium is bad, lower calcium, not so bad. Phosphorus. I showed you extensive data that phosphorus is the key to all of this. Mortality increases with a phosphorus that goes up above about 5. Try to keep the phosphorus in the normal range. You want to lower the phosphorus towards the normal range. You don't need the calcium phosphorus product. You don't get any more information from that than you do from the calcium and phosphorus. And with that, we have 3 minutes for questions. Yes?
What do you do with postmenopausal? You do bone density, she has osteoporosis, and maybe CKD 2, 3, and what do you recommend?
So the data is very clear. With CKD 2 and 3, and even into 4, the bisphosphonates are very effective. How do we know this? In the trials, a lot of these little old ladies who had creatinines of 1.5 snuck into the trials. They had GFRs that put them into CKD 3, sometimes into 4. Put them on a bisphosphonate. Make sure they get in a gram of elemental calcium in their diet. Much better than pills. Yogurt, if you have to use pills, but it's much better if they can take in their diet a gram of elemental calcium. Check their 25D level. If it's below 20, it needs to be repleted. And you can replete it with 1,000 units of IU of D3 that they can buy over the counter. But loading with calcium, which is what a lot of people do, doesn't work. The Women's Health Initiative, 45,000 women took supplemental calcium and vitamin D on top of what they were taking already. It did nothing for their bones and increased the rate of kidney stones. Yes, ma'am.
We're checking now lately a lot of 25 to high vitamin D. Do we need to give loading dose or just give methanestrid as it?
So it depends how low it is. I've seen patients who have levels of 4 and 6, and even I load them. But generally, most people do just fine on 1,000 or even 2,000 a day. Over about 10,000 is clearly toxic. There's no reason to go over about 2,000 a day. You're not taking a kid, who has rickets and trying to correct the rickets. If that's the case, you're a pediatrician, you're loading. Most of our patients kind of have little sort of lowish D levels. We give them vitamin D. They correct nicely. There's a new drug just on the market called Reality that's going to let you increase vitamin D levels more robustly. But it's just on the market. Yes?
Do we need to check also that level in dialysis patients?
So it's controversial whether a dialysis patient should be on D or not. We're talking about nutritional D. We tend to do it. We're in upstate New York. They don't get a lot of sunlight. Our patients, primarily African American, so they have a lot of pigment blocking it. We tend to give them nutritional vitamin D, but you can give them a multiple vitamin. It's got 600 units IU of D3 in it already. Yes. Yes, sir. And then I'll stop.
Is there a role for dialysis patients with primary hyperparathyroidism?
So, it's approved for patients in primary hyperparathyroidism who can't undergo surgery. If someone has primary hyperparathyroidism, find a good surgeon. I can't overemphasize that. A lot of surgeons think they can do parathyroid surgery. It's very tricky. In your practice, find a good surgeon, use that person over and over, and they'll be really good. I mentioned before, I have a little old lady who has severe osteoarthritis. She can't extend her neck. Kind of, one of these little old ladies. She has primary hyperparathyroidism. They can't do surgery. BID cinacalcet works perfectly, but she's taking this drug, which has GI side effects, for her whole life. As opposed to, in our place, it's literally outpatient surgery for primary hyperparathyroidism. We've got a well-trained endocrine surgeon. I think I'm getting the hook. It's been a pleasure. Great questions. I'll be around for forever. Thank you.